The SASM, School of Bangladesh, is extremely delighted today because we are having the national and international legendaries who are the stars of the galaxy of the medicine all over the world. And they are our esteemed guests today. Well, human sexual function is an essential component of life. So any dysfunction of any domain in men or women severely affect the quality of life, the sense of well-being, and the interpersonal relationship. Unfortunately, female sexual dysfunction is increasing in alarming number. From that study of Lumen and Swin, 40% of women experiences sexual dysfunction over the course of time. And also, ISSM, they mention that one out of six or five women are suffering from sexual dysfunction. But irony is that unlike male sexual dysfunction, these female sexual dysfunction are very less discussed, very less understood, and very less under noticed. So today we are going to discuss, we're going to listen all about the female sexual dysfunction guests. Though it is worth to mention that Kinsey, that's 1960, Master Johnson, Kalpan, Basson enlightened our knowledge, shedded some light on this mysterious subject, but still we have to go a long way. This is why SASM and ISSM, they're working hand. They are our inspiration, they are our guide, and they're always they are the hope of the race in sexual medicine. Ladies and gentlemen, we're going to listen the talk and the discussion, but just let me introduce a short, introduction of each guest. We are very happy today that this session will be chaired by Professor Roshanari Begum. She is actually past president of OGSB of Bangladesh, and she's working a dedicated advisor as a technical committee of COVID management in Bangladesh government. Madam is with us, and she apologized that she has to go early. So as soon as I finish my introduction, she will say something and then she'll leave. And we are very delighted that we have our special guest today, Dr. Lazanta Malaji and the Dr. Vasan SS. And we are very happy to have a renowned speaker and president, Professor Anna Maria Gilardi, and she's our keynote speaker. And we have also experts of panelists. They are Professor Dr. Muhammad Yukabi Chaudhry, Professor Dr. Sferdisi Begum, Professor Dr. Muhammad Jahangir Alam, and also Dr. Muhammad Shamsul Hassan is with us. So with this guest, we are going to start our discussion. So ladies and gentlemen, we are very much eager to listen the talk of Professor Anna Maria. But let us see her CV. আপনি চলে যাবেন ম্যাডাম? আমি ইন্ট্রোডাকশনটা দিয়ে দিই। Okay, let us request Professor, our chairperson, to have her opening remarks, and then she will leave.
I'm not leaving, but I will
good.
Continue. I'm just opening the meeting. So good evening. Already Professor Zina discussed about everything. So today I'm very much privileged and honored, and heartfelt thanks to the organizer for arranging this burning issue. And I'm very much grateful to Dr. Vasan, President SASM, and past President Dr. Lasantha Malaji. And they are allowing this for making this SASM Bangladesh. Actually, they are the main person. They acknowledged us, they were encouraged us to make this Bangladesh chapter for SASM. As Asian underdeveloped country, we always remain silent on this sexual chapter, but you allow us to light the candle. Thanks Bhasan again and Lasana. Thanks our Professor Salam, Professor Anwar, and our young brilliant Professor Maksud and Professor Jinatara, and all so many young doctors who came forward and brightened the candle and way forward. Actually, it has been shown that the attitude and values that may be culture specific related to sexuality will differ between Asian and the Western countries. There exist philosophical differences with long history, roots between Asian and Western cultures, regarding family structure and interpersonal relations, which may lead to the adoption of different beliefs as to meaning of sexual activity. For instance, the acceptance of sexual behavior as procreative in the Asian culture versus the recreative in the Western culture. This is the one example of how conflict between belief systems may have significant implications of individuals. And our women are already suffered from the sexual dysfunction and gender discrimination, psychological and behavioral disorder associated with sexual development and maturation, and also the paraphilips, that is the disorder of sexual preference. So we want to hear from Anna Maria to actually we want to go forward. So welcome Professor Anna Maria Giraldi, and also we welcome our panelists. And again, I thanks to the Professor Fassan and Dr. Lasantha Malawi. Actually, they are the main key person who encouraged us again. So I actually previously Professor Maksud was telling that we want to make maybe another our Bangladesh chapters. We want to do some things. So we are inviting you all to join us in this our Bangladesh chapters. Sexual we want to do something for our women to come forward, and don't hidden the chapters. We want to open the chapters. Welcome everybody.
Thank you, madam. Thank you so much for your brilliant talk. Well, now we are going to listen from Anna Maria Gilardi, but let us see her biodata. Can you share the photo of Dr. Anna Maria, please? Well, I'm honored to introduce her in this very nice webinar. Professor Anna Maria Giraldi, she is the senior consultant in psychiatry in sexological clinical at Psychiatric Center Copenhagen, and she is the professor in clinical sexology at the University of Copenhagen, Denmark, actually where she also received the medical degree and PhD. Professor Giraldi has been involved in basic research on vascular and smooth muscle function in male and female sexual responses, clinical research on pharmacological treatment of erectile dysfunction and female sexual desire and arousal disorder, as well as in research on somatic disease, psychiatric problems, and sexuality. Professor Giraldi has published more than 100 papers, editorials, and book chapters in the field of male and female sexual medicine. She is past deputy editor of the journal Sexual Medicine, past president of International Society for the Study of Women's Sexual Health, and now she's the president of the International Society for Sexual Medicine. So it is my honor to welcome Professor Anna Maria Giraldi. Thank you.
Thank you so much. Thank you so much, Dr. Nasreen, and thank you so much, Dr. Roshan, for this very, very kind and nice introduction. And also, I would like to thank Dr. Vassan as the president of the SASM and the past president, Dr. Lasanta, for organizing this. And I can only say it's always a pleasure to meet people from SASM. You're always so kind. And as I said when we were just chatting, I think you will know most of what I'm going to tell you, but I think we'll have a very, very nice introduction and discussion to this, I think, very important topic. And I really agree with the fact that it's so important to focus on women's sexual health and women's health, because that's 50% of the world. And it's something that we have more and more focus on. And we know that there are differences in cultures. And I think we can learn so much from each other by sharing knowledge and having these webinars. So thank you so much for the introduction and inviting me. I'll just find my slides so I can share them with you. So I was asked to give the title, and I thought that as it's the SASM school, I would just cover the basic of female sexual dysfunction. But when I prepared the talk, I realized it's so difficult to say what is the basic and what's not the basic. So I'm afraid I have so much I would like to discuss with you that it will be a long talk, and I think it's going to take about an hour. And also, if I speak too fast or something is unclear, just let me know, and I'll stop and explain if there's something that I tend to speak a little bit fast. There's so much we can talk about. So first of all, I just want to say I have been involved with the industry, so those are my disclosures. But as it is a SASM arrangement, it's a SASM webinar, I just want to introduce the International Society for Sexual Medicine, of which I'm the present president, because I think that, as it was said in the introduction, sexuality is so important for people's life. And we really have a vision and a mission in the ISSM that every human being has the right to a healthy and satisfying sexual life. And by this, we also have the mission that we as a society would like to be the most trusted and respected source of information, education, and professional development on human sexual health through the delivery of world-class publication, research findings, online arrangements, in-person opportunities where we can exchange knowledge all over the world. So this is really the mission and the vision of the ISSM. And the way we do that is that we rely on all our affiliated societies, all the regional societies. And SASM is so amazing because SASM is the newest one and it's the one that grows, and you have so many wonderful initiatives. You're really doing so much work and you're growing and progressing so much within the field. So the only way ISSM can exist is based on the regional societies, and SASM is really one of the cornerstones now in our society with all the work you do and all the focus you have on sexual medicine in your region. So here you can see the reach out of the ISSM. So it's just to tell you that we have been growing. So we have actually regional societies all over the world: North America, South America, Europe, the Middle East, the Asian Pacific region, and then the South Asian region. And we also have representatives in South Africa, but we are working and try to establish an African society too. So I think that this is the beauty of the ISSM, and then it's always, as I said, so nice to be in contact with the regional societies. So if some of the listeners to this webinar are not already a member of SASM, I really would recommend it, because one of the benefits of being a member of the SASM is then you also become a member of the ISSM. And if you're interested in sexual medicine, there are many benefits. If you go to our meetings, there will be reduced registration fees, but you will also have online access to our 3 journals, which are the Journal of Sexual Medicine Reviews, and Sexual Medicine Open Access, where clinical, basic research, all kind of research in sexual medicine on both men and women and transgender are published. And we also have a video journal for urologists. It's basically a surgical journal. And then we have what we call the ISSM University, which is a university, a virtual university with different webinars, with different lectures on different aspects of sexual medicine. So if you would like to teach someone, you can always go there and you can find a lecture that might be helpful also for your own knowledge and sharing of knowledge. We have a members only section. We have Find a Provider directory, where you can try to see if you want to find a provider within the field with different specialty. You can also find them there. So another benefit are that we have also established our webinars. We have established, with the pandemic, we were not able to meet in person. So we established a series of webinars, and the next webinar, each webinar is the last Thursday in the month. This is the one that will be in September. We will have one tomorrow. I'll show you the topic at the end of my talk, so you might sign up for a webinar tomorrow. But these are webinars where different aspects of sexual medicine are covered. So we can meet online all over from the world, and they are open to everyone. It's not just for members. So we're also introducing what we call Ask the Expert program, where the members will have access to different experts. So if you, as a regional society, say, we would really like to spend 10 people to have a discussion with this expert or an expert in this field, then you can contact the society, and we can try to arrange small closed meetings where you can actually ask the experts on different topics. It can be how to publish a paper or something on male sexual dysfunction, on female sexual dysfunction. Many different experts will be available if you are a member of the society. So if you're interested and not already a member, you can find us on different social media on Facebook, LinkedIn, Twitter, and Instagram, and also Google us and find our webpage. So this was a little advertisement, and also I think try to emphasize the benefits and the value of both the International Society and regional societies for people that are interested in working in sexual health for both men and women. So having said that, I'll go to my topic, the basics of female sexual dysfunction, and you will see on my slides that FSD is female sexual dysfunction. So what I would like to discuss is what is sexual desire? And the reason is that sexual desire is something that women very often do not have. So we need to discuss a little bit what is desire if we want to treat women for desire problems. I also want to talk about what is female sexual dysfunction, what are the risk factors, and how can we treat it. So if we start with sexual desire, I think we all think we have an idea of what is sexual desire because we all have a subjective feeling of our own sexual desire and maybe our partner's sexual desire, but it can actually be described in many ways. This is one suggestion saying that it's a motivational state and an interest in objects or activities, or a wish, need, or drive to seek out sexual objects or to engage in sexual activities. And it also says, as it was also mentioned a little bit in the introduction, that sexual desire maybe is the most single common sexual event in the life of men and women, because most people will experience sexual desire at some point in their life. Some people will experience a lot, some people will experience less. But what is important here is that it can be described in many ways. It can be described as a drive, it can be described as a motivation, or it can also be described as a wish. And I really like the American psychiatrist Stephen Levine, who said that desire is always composed of these three components. There's a drive, there's a motivation, and there's a wish. And he also says that desire can actually go from being something that you actually don't want at all. It can be an aversion against sex. That's the very negative desire. Or it can be a passion in the other end of the spectrum. And then you can have like what's in between. And I think one of the problems is that most people, when they fell in love, they will have the passion, and that's what they remember. And then when normal life goes on, maybe they move a little bit to the left, and then it's going to be a need, it's going to be an interest, maybe it's something they're a little bit indifferent to. And the people we see in the clinical setting most likely would be on the negative side, even having an aversion towards sex. So the way most people think of desire is that it's something that is very positive, but we also have to recognize that throughout life, throughout relationship, it might change and become something different, maybe even more neutral or negative. So if we look a little bit, what is drive, what is motivation, and what is wish? Drive is what could be described in this model as the biological part. And if we think of that, that means it's the hormones, it's the neuroendocrine physiology, it's the anatomy. And already here, this is maybe the difference we see between men and women, that because men have more testosterone, they will have more drive than women, because we have hormonal differences, because we know that if women get testosterone, they get more drive. So drive can be described as the biological part. And some of the problems we see in relationships may be that there's a difference in drive because there's a difference in the hormonal milieu in men and women. So that's a very simple explanation, but drive is the biological part of desire. And that might change throughout life. We will discuss that. Then we have motivation, and motivation is what you could call the psychological component. And I think it's so important to remember, because sometimes we think that desire is only drive, it's only biology. But especially in women, but I think also in men, but especially in women, motivation is a very, very crucial part of desire. So motivation is the psychological component, and that can be influenced by how is your mood? Are you tired? Are you happy? Do you feel sorrow? Are you in love with your partner? Do you quarrel? Do you disagree with your partner all the time? Do you feel disrespected? Have you known the partner for very, very long, so you're a little bit bored or annoyed by the partner? Has the partner been cheating on you? Has there been infidelity? Has you yourself been in love with another person? So these are all the psychological components that we sometimes forget when we talk about desire in women, because we forget that desire is so influenced by the motivation, by the psychological factors. Do we, I think basically, do we like the partner? Do we feel respected? Are we attracted to the partner we have? Because drive might be a little bit more independent of the partner and where we are, but motivation is so much in a context with other people. The social part, or the wish, that is the cultural part, and I think that's, as was mentioned in the beginning, so important to remember that culture has such huge impact on sexual desire, because that's the cultural part. Is what is the meaning of sex? What is allowed about sex? What are you told about sex? What are the rules about how you can express sex? And that is something that starts when we are children, and it is developed throughout life, but it can also change throughout life. And Stephen Levine will, in his model, say that the cultural thing is something that comes from the culture, but it's like mediated through the motivation. So it's something that is put into our psychological state, and then it's expressed through our psychological state. So this is just a way to talk about desire, because I think if we want to treat women's sexual problem, we need to talk about what is the motivation, what is the wish, what is the cultural context where we have sexual desire and where we have sexual activity and sexual norms. And what he also says, and has also said, is that this might be variable with genders. So they are different. We have different drive, we have different motivation and wish for men and women in different social situations. Are you married, non-married? Are you old? Are you healthy? So it's of course influenced by how our life is and what culture we are living in. So this was just to set the stage for discussing on what is then a sexual dysfunction. So if we look, and what was also mentioned in the beginning is that we are standing on the shoulders of many clever, intelligent people. And some of them develop the sexual responses where they talk about the different sexual responses we have. We have desire. I talked a lot about desire. And then if you have desire, you will also have arousal when you go into a sexual interaction. So you have desire, then you have the arousal. And then when the arousal is large enough, you are able to have an orgasm. And this is showing the response for women, that some women can have more than one orgasm, but that is the peak, and then the body will go back to what was there before. This is a very classical way to describe the different phases of the sexual response. And this has been challenged, and Rosemary Besson was also mentioned in the beginning, because Rosemary Besson about 15 years ago challenged this and said, maybe it's not that we have desire first and then arousal and then orgasm. Maybe you can do it in a different way. So she developed a model describing or trying to describe what she saw as a model for many women's sexual responses, saying that the reason why women do have sex is not necessarily desire. And that talks a little bit into the model of Stephen Levine, saying that it might not be drive, but it might be motivation. It might be the wish of the woman to be intimate with her partner, or the feeling that she should have sex because it's expected from her. So she will be motivated to go into the sexual interaction, and then she has sexual stimuli. And depending on her psychological and biological factors, she will start reacting in her body, which could be called sexual arousal. So in this way, you could say that the woman might just have the wish to be sexual active. She might have the motivation to be sexual active, and then she receives sexual stimuli, and then she becomes more and more aroused, and then desire develops, and then she might have physical and emotional satisfaction. And this satisfaction creates emotional intimacy. So the next time she will think of sex or the partner will approach her, she might have the receptivity or the motivation because she knows this is something that's going to be nice. I might not have desire now, but I know it will be nice later on. So that might be the motivation and the reason for engaging sex. So this is a completely different way to describe sex, but I think it's a way that many women, especially in longer term relationships, will experience sexual desire more as a motivation. Of course, this model also has what you could call the drive, saying that some women, of course, will experience the drive for sex and say, I just want to have sex because they want it. But we need to recognize that a lot of women might say, it's more motivation, it's more I'm receptive to the sexual inputs, the sexual cues I get from my partner or the one I'm going to have sex with. So based on this, we can also say that there are different sexual problems in women. And depending a little bit on where in the world you are and what specialty you have, you will see different groups. Gynecologists will see a lot of women with pain. Psychiatrists will see a lot of women with desire problems. So it's a little bit depending on where you are and what specialty you have and in what context you're living. But you can say that women can have problems in desire in the different phases, desire, in arousal, and in orgasm. And then we have what we call the pain problem, which can be the pain when you have sex, or it can be vaginismus. And very, very often there's an overlap. If a woman doesn't have desire, then she will have problems in becoming aroused. Maybe she cannot have an orgasm, and it might even hurt. Or the other way around, if you have pain all the time you have sex, you will of course lose your desire because no one has desire for something that is painful. And then it's also difficult to become aroused and even more difficult to have an orgasm. So it's so important when we focus on the history to find out what was the first problem and what came on later. The dysfunction can be lifelong or acquired, meaning it can be something you have had all your life. Vaginismus, you have never been able to have an intercourse, it's always been there. Or it can be something that comes when you go into the menopause, it's difficult to be aroused due to hormonal problems. It can be generalized, meaning it's always there, or it can be situational, meaning it's only sometimes or in different with different partners, if you have different partners, or it can be in different situations. And then for it to be a sexual dysfunction, it needs to be distressful. And that's something that discussed a lot about. Maybe a woman doesn't have desire and she doesn't care because maybe she doesn't have a partner, and then it doesn't matter. But if she's distressed about the condition, then it's called a sexual dysfunction. So a lot of women might have a problem that's not distressful, and then it cannot be defined as a dysfunction, but still it might be a problem for them. So what I think is so important when we talk about sexuality in both men and women, but here we talk about women, is that we need to remember that we have a constant interaction with the brain and the genitalia, because desire is something that happens in the brain, but sex is something that also happens in the genitalia. So the brain will send out the signals to activate the genitalia. And if the brain is sending out saying, this is something that is negative, this is something I know gonna hurt, this is something I don't like, I don't have desire, the genitals will not react in a proper way and not be ready to have sex. And the other way around, if the woman experiences something nice in her genitals, it will send signals to the brain saying, this is something that is so nice, I really want to continue, and the desire will increase. But if she's experiencing something that's not nice in her genitals, like pain, it will very quickly go to the brain and say, this is something that is not very nice. This is something I don't want to be in. And then it will close down the desire. So we just, depending on the specialty we have, the psychiatrists have to remember the genitals and the gynecologists have to remember the brain and this constant interaction between the two organs that are the most important sexual organs. So if we look a little bit on how do we define sexual problems in both men and women. The WHO came out with the ICD-11, which are the new definitions, and they defined hyperactive sexual desire dysfunction that it is the absence or the marked reduction in desire or motivation. So it can also be motivation to engage in sexual activity manifested by any of the following. It can be the reduced or absent spontaneous desire. That is the drive, meaning you don't think about sex, you don't have a drive for sex, you don't fantasize about it. Or it can be the reduced or absent response to desire, responsive desire, if you are confronted with erotic cues and stimulation, meaning that you go into the sexual activity, but nothing will actually turn on your desire. Or it can be the inability to sustain desire interest as you have started it. So this is a way they try to cover all the aspects of desire, saying that also the lack of motivation can be a desire problem. It needs to have been there for a while, so it's not enough that it's something that has only been there for a week or something like that. It has to have a certain time of period, and that's of course, if they haven't put month on it, they just say it has to have been there several months, and it has to be distressful for the woman. And in the clinic, it might be a problem with the distress, because a lot of women will come to the clinic because the husband is very distressed. So they will say, you know, actually, I don't care if I have sex or not, but there's a lot of distress from my husband because I'm not interested in sex. And that's what might cause the woman distress, is actually the interaction with the partner. And that can also be called a difference in sexual desire, or maybe she doesn't have a problem, but at least there's a difference in sexual desire and you need to work on that. If we look at what female arousal disorders are, or dysfunction, it is the marked reduction in response to sexual stimulation in women by the absence or marked reduction in genital response, meaning that the woman will not lubricate, she will not have engorgement of the genitalia, the sensitivity on the genitalia will not be very profound. And this is something that we see especially in women in the menopause because of the lack of estrogen, so they have an impaired response in their genitals. It can also be described as the absence or marked reduction in the non-genital response, things like the hardening of the nipples, flushing of the skin, increased blood pressure, increased heart rate. So it's focusing a lot of the more bodily reactions that they are missing, that the woman is not like feeling the excitement in her body, either in the genitals or the rest of the body. Orgasmic problems, I have to find it. They say it's anorgasmia is the absence or marked infrequency of the orgasmic experience, or markedly diminished intensity of the orgasmic sensation, and also if there's a huge delay in orgasm. So it can be many ways that either you cannot have the orgasm, or maybe it takes very long time to get it, or maybe it's just a very small sensation and then that's it. And what is so important is that it's something that has to be there despite this good sexual stimulation. Because if the woman doesn't have desire, then it's a desire problem, and then you can easily understand she cannot have an orgasm. So this is in women that say, I have desire, I do feel arousal, but I cannot get an orgasm, or it's changed. And some of the women will be women that have never experienced an orgasm. We see especially younger women that find it very difficult, but it can also be women in the menopause that due to hormonal changes suddenly experience that the orgasm has changed a lot, or it takes much more stimulation to get an orgasm. Like we see, it also takes more stimulation for men to ejaculate when they get older. Finally, we have the pain problem, and I'm not a gynecologist, so I think for me, it's sometimes so difficult to describe all the different types of pain problems we can have in women. But we have what we call the female genital pelvic pain syndrome, and that can be many different types of pain. But when it relates to sexual function and sexual medicine, which is the topic today, I think the most important are the dyspareunia, which can be the described as a genital pain that you experience just before, during, or after sexual intercourse. So that is something that's related to intercourse, and it can be both superficial or deep, meaning it can be like in the superficial area of the genitals, or it can be more deep in the abdomen. Vestibulodynia is the severe pain upon touch, when you touch the vagina, or you try to put something into the vagina in the vestibule, in the vulvar vestibule. And that's something that will, of course, also cause pain when you have sex, but it can also cause pain. And those of you who are gynecologists will know that it can cause pain when you try to use a tampon, if you do a gynecological examination, if you sit down somewhere when you experience pain. And then you have vulvodynia, which is a chronic pain. And then we have vaginismus, which is like the involuntary spasm or contraction of the pelvic floor muscles that makes it impossible to put anything into the vagina. So everything can be covered by the genital pain syndromes. If we look at the definitions in the ICD-11, they have tried to put something in gynecology and something in the sexual health chapter. And the first one is the sexual pain and penetration disorder, which is what they call sexual pain that refers to a marked, a persistent, or recurrent difficulties related to the experience of pain during sexual activity, which are not attributed to an underlying medical condition, insufficient lubrication, or age-related changes. So the sexuological definition in the new ICD-11 is focusing on women with pain where you cannot identify any reason. So you cannot find an infection, you cannot find scarring, you cannot find any dermatological changes, you cannot find lack of hormones. So it's something where you cannot identify a cause. And some of the etiology behind it, we'll discuss that later, might be that they contract or they have hyperactivity in the pelvic floor and fear of pain. So that will like contribute to the pain. And it might have started with an infection, something that you could actually treat, and that was treated, but the pain will stay there. The other part of the pain problem in ICD-11 is the dyspareunia, where they say it's a symptom of the genitals caused by physical determinants. And then it can be an infection, it can be dermatological things. So this is something where you can actually find it and you can treat it, and then you hope that it's going to disappear. So these were a little bit an overview of the different problems women can have. And what is very, very nice about the new ICD-11 is that they also give you the possibility to say, what do I think is the most important etiological factor causing this problem? So if it is a woman with a breast cancer who went through surgery and anti-hormonal treatment, you might say this is associated with medical conditions. Maybe she received radiotherapy on her genitals due to cervix cancer. So then you can say, I think this is because she has pain because she has a medical condition, or she has desire problems because she's an anti-estrogen therapy due to her breast cancer. If you think it's something that's associated with psychological or behavioral factors, including mental disorder, meaning if she has a depression, you think that's the main factor, or if there are other like anxiety or stress, you can say, I think this is the most important factor. It can be associated with the use of psychoactive substances or medications like antidepressants, for example, have huge negative effect on many people's sexual function. It can be associated with the lack of knowledge or experience, meaning if you're not educated about sexual function, if you have never experienced anything and it doesn't work because you actually don't know how it should work, then that can be the main reason. If you have a partner you're not in love with, which is always disrespectful, might be a partner that is violent, you think this is something, it's a relationship factor, then you can say that's the main reason. And you can also say, I think this is cultural factors. If you have cultures where women are not allowed to be sexually active or are repressed a lot, then you can say this might be the reason. And then you can also have other reasons that you could call other specified theological considerations. So the new way in ICD-11 to look at women's sexual problems and sexual function is really nice because it integrates that you need to look at the biological factors, the psychological factors, and the social factors. And sometimes it's one condition that is the main reason. Other times it's another one, and there isn't one size that fits every woman. We need to look at the individual woman. Just to say, I keep saying that the woman needs to be distressed. So what does distress mean? Distress means that the woman is dissatisfied by her sexual life, and she might feel bitter, angry, ashamed, inadequate, hopeless, unhappy, concerned, having low self-esteem, being depressed about her situation. So these are just some of the words that some of the women will put on them. If you say, what does this sexual problem, how does it have a negative impact on your sexual, on your life? These might be some of the words. This is from a study where they ask women to describe distress or what was the distressful meaning of their life due to their not functional sexual life. Just to say that age has to do with both distress and sexual dysfunction. This is from a large American study, and I apologize, I don't have a study from your region of the world, but I think it's most probably is going to show the same problems, saying that if you look at desire, aroused, and orgasmic problems, you can see the black line this is something that increases with age in women, and especially there's a steep increase when the women go into the menopausal period. In from the 45 years and up, there's an increase. But if you ask the women whether they are distressed about the problem, does it bother them, you can see that it goes down. So usually younger women are more distressed than older women. And there might be many different reasons for that. One is there might be changes in the hormones, that the drive part of women's sexuality will go down, so they don't have the same need for sex, but also that culture and norms would say that older women are not very sexual. So they are not distressed about it because it's not expected for them to be sexually active, or maybe because the partner is not very sexually active because he's getting older too. So there's not a lot of pressure on the woman. So she doesn't care a lot whether she has desire or not. So if we combine it, the frequency will be almost the same. If you need to have both a problem and distress to have a dysfunction, it's almost the same in all age groups, but that's because one goes up and one goes down. So it's especially the younger women that we see in clinic because they are more distressed. So they're the one that would like to have treatment because they are distressed about the condition in general. This is a study where they looked at orgasmic problems, and you can see it's the same with orgasm, that orgasm is becoming more and more difficult for women with age. And I forgot the one with pain. I apologize for that. But we also see that pain is something that increases with age due to the transition, the menopausal transition. So this was an introduction to the different problems women can have. And as they always overlap so much, the difference from when we hear a talk about men, it's always a little bit easier, I would say, when you talk about risk factors for sexual dysfunction in men. We know that diabetes, cardiovascular disease, depression, huge risk factors for erectile dysfunction. And then we have, low desire in men. It's going to be testosterone. That's going to be very important risk factors. But because there's such an overlap in the different dysfunctions in women, it's always very difficult to say, this is the most important risk factor for this dysfunction. This is the most important for that. So what I'm going to present is like the overall risk factors for sexual problems in women, because there's so much interaction and overlap. So it's difficult to pinpoint in most of them each dysfunction and each risk factors. So as I mentioned, it's so important that we always think biopsychosocial, because if we only look at biology, we're going to miss a lot. If we only look at culture and social life, we're going to miss something. And if we only look at the psychological aspects, we're going to miss something. So we need to think about all the three groups of risk factors. this is called the dual control model. And what I like about that is that a lot of people can have risk factors, but how our sexual life is functioning is a balance between the positive and the negative things on the scale. So if you have a lot of positive things on your right side, which is called excitation, something that is positive for sexual function, then you will have a sexual life that most probably will work. But if you have a lot of negative things, that will be the overwhelming part, or it's going to tip the scale to the wrong side. And sometimes there will be a change in women's sexual life or their life. So something that used to be good might move to the other side. So something turns out to be negative, or a negative aspect is added to the scale. So I think it makes so much sense when we think about positive and negative things to think of this model saying, what are the positive things? What are the negative things having an influence on the woman's sexual life? And you can use that, of course, in men too, because the fact that you have diabetes and that's a risk factor might not have any impact on your sexual life, but then maybe something happens that you are fired from your job, you're very stressed, and then suddenly you start having sexual problems that you didn't usually have. So this is just to introduce you to the thinking of the tipping point model. And when I discuss that with my patients, I usually compare it to a car, saying that for a car to drive, you can do different things. You can either press the gas pedal, that means all the positive things. So if you know that for your sexuality, or she knows that for her sexuality, it's very important that the children are not in the same room, that she's not tired, that she is not having her period, then that's the gas pedal, because then you can take out the children of the room and you can turn on the gas pedal. Or you can take your foot away from the brake, because also a lot of people will know that there are some negative aspects, or some aspects that have a negative impact on their sexuality. So when we discuss that with women, sometimes it's a very good picture to use, saying, what are the gas and what are the brakes in your sexual life? A typical brake for women will be a very demanding husband just coming home, demanding to have sex without intimacy. That would be a brake, and she would say, no, I'm not going to do anything. So the gas pedal would be the opposite, of course, that he's showing more affection, showing more intimacy, maybe, participating a little bit more in the family, or whatever can be the problem in that couple. So if we use that model to look at the biological, the psychological, the social and cultural aspects, I'm going to look at the brakes, because that's what we know most about. But we can say that the opposite of the brake is the gas pedal. So we put the plus instead of the minus, because we know that risk factors, the biological risk factors for sexual problems for women, are aged. I showed you that with increasing age, women get more sexual problems. We know that menopause is a risk factor. There's a drop in estrogens. There's also a drop in testosterone gradually throughout women's life. So both the drive and the arousal response and the orgasmic response will increase with age due to the changes in hormones. We know that common problems as genitourinary tract infections is a huge risk factor that we sometimes forget. It makes it hurt to have sex. It makes the women being afraid of leaking urine. It makes the women feel they are smelling. So just the fact that you have urinary tract infections, or you have prolapse or incontinence, is a risk factor for women's sexuality, both for orgasm, desire, and arousal. We know that a lot of chronic diseases like diabetes, thyroid problems, multiple sclerosis, cancer are risk factors due to both the overall health factors, that you're tired, feeling sick, don't have a lot of energy, but also the specific changes like neurological changes, neuropathy with diabetes, cancer changes, maybe the breast is missing, you don't have the same sensation in the genitals and the breast. So there are so many aspects of having these large somatic diseases. Also, we know that impaired physical health. If women do not feel healthy, if they are not healthy, then it's going to have a negative impact on their sexual health. So sometimes it also helps the women to become more physically active, become more healthy. There are studies showing that women that if they start exercising and become more physically healthy, they also have a better sexuality. Then we know there are many medications, especially the psychotropics, that have a negative impact on women's sexual health. So most types of antidepressants, and the few women that get antipsychotics, that's not a lot, but a lot of women will have antidepressants, and also anti-estrogens, if you are treated for breast cancer, will take especially the desire and the arousal away. And then, as I mentioned, if you have radiotherapy, surgery on your genitals or your breasts, that will also have a negative impact. So there's so many biological factors that will have a negative impact on women's sexuality. But there are also a lot of psychological risk factors. And I think the most important one overall is depression. There are so many women with low desire that actually are depressed. And you know there are more women than men that are depressed. So you should always think depression if women talk about low desire, because depression is the one major risk factor for sexual problems. And I would say menopause is the second one. Also anxiety. If you have a self-perceived bad mental health, so if you're not feeling well psychologically, also you'll not have the energy to be sexually active, you'll not have desire. If women have a negative body image, a lot of women do not like their body. And then it's very difficult to be free and like sex because they don't like the body that sex is experienced in. And that might have a very negative impact on their sexual life. Medication or alcohol abuse. So it's not only the biological effect of medication and alcohol abuse, but it's also the fact that you are addicted to something. People that are addicted will very often lose their desire because the brain is satisfied or has its reward system fulfilled in other ways. So that might have a very negative impact. It's also more difficult to be in a relationship if you have a medication or alcohol abuse. If women are stressed, if they have a very, very stressful life, very often they don't have the energy for sex because maybe they just prefer to sleep because they're so tired. And if they are distracted or what we call self-focused during sex, and that often goes together with women that don't like their body, that if they keep thinking, how do I look now when I have sex? Do I smell strange? Do I look strange? Do I sound strange? They cannot be in the experience, but like looking at it from the outside, that will have a negative impact. And also if they're distracted all the time and are afraid that the children will come into the house or to the room, or the mother-in-law is sleeping next door or something like that, that of course has a negative impact too. And then I say the menopause also is a psychological thing, that there are studies showing that women in the menopausal transition, the psychological part of it, feeling old, what is my role now? Does anyone want me now? I'm not being able to have children anymore. That also might have a negative impact on the sexuality. So it's not only the hormones, it's also the psychological transition you go through when you go through the menopause. Then we have the social and relationship. And I think what we also need to remember as a very, very important one is the partner's sexual problem. If the partner has a problem, the woman will very often also have a problem. If he has erectile dysfunction, he might be very sad about it. He might be angry. And the woman will start saying, I don't want to have sex because it's becoming a bad experience. If the partner has a premature ejaculation, he might be finished before she even gets started. So that's going to discourage her from having sex. So always ask about the male partner's sexual problem, or if he has any. If there are relationship problems, this is a very important factor for women too. If they don't feel good about their partner, if they're arguing all the time, I have mentioned it, that's not very encouraging for women to have sex, because it's very much about intimacy. So if you don't feel you have intimacy in the rest of your relationship, maybe it's very difficult to have intimacy in the bedroom if you don't have it in the rest of the house, physically speaking. And a lot of women will also experience that they don't get enough stimulation, that maybe the partner is very focused on just intercourse, not having foreplay. So maybe she's not lubricated enough. Maybe she doesn't become aroused. So if you think of the Basson model, if she doesn't have the desire and arousal from the beginning, it's something that needs to be developed. So if there's a partner with not a lot of focus on foreplay, then maybe that's the problem. So sometimes it's also a more pedagogical thing. You need to talk with women and men about what are they actually doing, because if the partner enters the room with an erection and say, now I want to have intercourse, and she's not ready, then it might be difficult. So lack of sufficient stimulation is something that is very, very common. I talked about lack of intimacy, lack of privacy, and then you could say lifetime events. If you are bothered by old parents you need to take care of, very small children, problems in the family, social problems, loss of work. During the pandemic, there's been a lot of talking about sexual problems because people are concerned about their finances. So something that happens in life very often, not to generalize, but we see more often that has an impact on women's sexuality than on men's. It's like the men's drive is a little bit like a basic drive, but the women's is more vulnerable to all these lifetime events that might change pregnancy, breastfeeding, the menopause, as I said. So that's important to remember too. And that's like small children at home. And then we know that if it's difficult for the couple to talk about sexuality, then it's also difficult to talk about something that's you would like to be changed, and then it might develop to a sexual dysfunction. Then we know that, as was mentioned in the beginning by the introducers, that we also know that culture has a huge effect. And I think it's very interesting when I visit your region or when you visit my region, we can see that it's different types of sexual problems that women will have. And I think that's very much due to our different cultures. We know that it is a risk factor for women's sexual problems if they are brought up in a very restrictive sexual moral, because they don't learn anything about sex. They don't know how it's working. They are not educated. So they don't know what is right, what is wrong, what is normal, and they might have some strange idea about how it is. And if you also think that sex is only to have children, then it's a problem, because then you don't talk about pleasure, then you don't talk about what do I like, what don't I like, then it's only about having intercourse and becoming pregnant. And we know that in cultures where women are suppressed, it's less easy for women to express themselves sexually, and that increases the risk of having sexual problems. And then, of course, in countries where you have female genital mutilation, that's a very physical problem, but it's also a repressive act towards women. So it's both a physical and a psychological aspect that really inhibits women's sexual function. So this is something that is very difficult to change, but we can discuss with the knowledge we have as healthcare providers. We have a knowledge of what is the meaning of culture, like we have the knowledge of the rest of the factors I talked about, and maybe discuss with the individual couple about what is their cultural norm and how do they have sex and how is it influenced, how does it express itself in the culture you live in. So that also gives different sexual problems in different countries and different parts of the world. So just to summarize, I think that this makes it so sometimes people say this is why it's so difficult to work with women's sexual problems, because there's so many factors that you need to take into considerations. But I think when it comes down to the individual talk with the woman, very often you can pinpoint, okay, this started with this and this, so maybe this is where we should start. If it started with the mother-in-law moving into the house, maybe we need to discuss what happened when she moved into the house. Or if it started when you went into the menopause, then we need to find out what changed. Maybe you can treat it with hormones. So it's so important to have a good assessment, because if the problem started with the mother-in-law moving into the house, you cannot treat it with hormones. But if it started when you went into the menopause, you can treat it with hormones. So that's really emphasizes that it's so important to have a good history. So that brings me to the treatment. And Sometimes it's easy, sometimes it's not so easy. But what I think is so important is to think that if you enter sex with a negative thinking or effect about having sex, is most probably going to go wrong. And a lot of women who have experienced, for example, pain or a lot of sex without having desire will be negative when they enter sex because they don't expect anything good from it. And that will activate the sympathetic nervous system, and it will make them change their attention or have the attention all the time to the negative things. So if you are expecting pain, you will look for the pain and you will not experience what is nice. And that will, again, intensify the pain. It will make a vicious circle where you, again, look at the negative things. You will not see any good things at all. Or if you say, oh, I never have desire, my husband is always putting pressure on me, you will forget to see when you actually have desire and when he's not pushing you to something. And then you will be anxious about sexual future activity. So I think a lot of the focus is try to break this vicious circle and try to put focus on the positive things and try to promote them, put a little bit more on the positive side of the scale than on the negative side. So the way we do that can be described in a model. And if you all know it, I apologize, but I really like it. The Pleased model saying that the first thing we need to do to the women is to give them permission to discuss sex. And the permission needs to come from us, because if they feel that it's something you're not allowed to discuss, they're not going to talk to you about it. So we need to give them permission to talk about their problem and to what their experiences are. And a lot of women will be helped by that. And that's why it's shaped like a triangle, because a lot of women will be helped by permission. The next step can be to give them limited information, like saying, I know that if you are very tired, you lose desire. So maybe that's what's happening with you. Or we know that it's changing with menopause. Or we know that if you have diabetes, it might be a little bit more difficult. Try to explain so they don't feel very strange that something is so wrong with them. Give some information about common knowledge about what this is about. And then we might have what we call specific suggestions. And that could be, maybe we should try to give you some vaginal hormones, or maybe you should try to have more privacy with your partner. Maybe you should try to have more foreplay, or maybe you could do this and you could do that. That's limited information and specific suggestions. And that is something that most healthcare providers can actually do. And then we have helped a lot of women, because a lot of women will be helped by that. So only the fact that you tell them they're not crazy or nothing is really wrong with them, and maybe it's something they can do something about, will help them. And then there will be someone left that need more intensive therapy. And that could be like psychotherapy or more long relationship therapy or something that is more intensive. But a lot of people will be helped by the first 3 steps. So when I take the history, this is from a Swiss gynecologist, some of you might know, Johannes Bitzer, who always say that in your head, you should have this table saying when you talk to the woman, there will be some factors that are predisposing her for having sexual problems. That might be a sexual assault when she was a child, or having diabetes. That could be a biological one. It can also be psychological or social cultural. The social cultural could be that she doesn't know anything about sex in the culture where she grew up. So the woman has some predisposing factors, and then something participates the problem. Something starts the problem. And that could be the mother-in-law moving into the house, or it could be the menopause, or it could be the surgery for breast cancer. And then there's something that's going to maintain the problem. And maintaining the problem could be a psychological one, could be that the couple is fighting all the time about the problem. So even though she now has diabetes that is well treated, then the maintaining the problem is that now there's a fight all the time between the couple. And it helps you a little bit to try to find out, where do I put my effort when we try to change the problem? Because sometimes it's nice the predisposing sometimes it's difficult to change it because it has always been there maybe, but something participates it, and that can tell you a little bit about how did this problem come, and then what can we take away so we don't maintain the problem while we work at it. So how do we treat them? And that's like the difficult story, because we don't have, like in men with erectile dysfunction, we really have a good drug or really a good treatment. So it's always a little bit a mix of different treatments. So we have the basic counseling, which is, as I said, to talk to the women about what is sex, what do you expect from it, inform them about function, inform them about what is normal, what is not normal. And then you have the hormonal treatment, and the hormonal treatments are, of course, for women that don't have hormones. So the hormonal treatments will be treatment with estrogens. It can either be systemic estrogens. I think there's someone on the line. Is it only me that hear it?
No, please mute yourself, please.
So thank you. So I think that hormones can be both systemic, or it can be vaginal hormones, especially the systemic will be for desire. The vaginal ones will be for pain problems and arousal problems. And then some places in the world, you can use testosterone. In Europe, we don't have any products. I think Australia and the US are the only places where there is a product for women, but most places in the world, if you think that the drive part, that is really something hormonal, you can try to treat with small doses of testosterone that are usually formulated for men. And then we have DHEA, which is a pro-hormone for testosterone, which in some countries, especially in the States, can be bought as you go over the counter. And then we have Tibolone, which is also an hormonal replacement therapy with a small androgenic effect. So depending on where you are in the world, there will be different hormonal products that can be used for women that are in the menopausal transition and have sexual problems, where you think this is something that's related to hormones. Then we have a lot of different drugs that have been proposed or even approved for treating sexual problems in premenopausal women. And this is something, I'm just going to mention it because we don't have it in Europe. They only have it in the States. But flibanserin and bremelanotide are two drugs that act directly in the brain and are increasing desire. So they are increasing the drive. They are acting on the serotonergic and the melanocortin systems and enhance sexual desire. So these are for women where you really think there's no cultural, there's no psychological, there are no relationship problems. These are women that have lost their drive and you want to increase their drive. But it's only for premenopausal women. It's only something that are used in the States, and it's not used that much as I think they wanted it to be. Then it has been discussed if you can use PD5 inhibitors to women, and it's not licensed to do that, but it can be used in women with arousal problems because it only creates more lubrication. It doesn't create desire because it doesn't work in the brain. It's like in men, it works in the genitals. It will increase lubrication, and it might be relevant for women with neuropathies, women with sclerosis, but it's off-label. It's something that is not a wonder drug, but it can be used for a few women. And then you have the selective estrogen receptor modulators, which are treatments that are non-hormonal but will increase lubrication and decrease atrophy in the vagina. So these are especially for women with pain and lack of arousal in the menopausal transition. So what most often are used for women are actually the more psychotherapeutic approaches. And we have the traditional sex therapy, which includes that you actually increases intimacy and communication in the couple about their sexual needs. And you have a lot of focus on the foreplay. You have a lot of focus on intimacy. You have a lot of focus on covering both partners' sexual needs. Sometimes you tell the couple not to have intercourse so you can focus on all the other aspects of intimacy. So you have this stepwise treatment where you actually have a lot of focus on communication, behavior, and intimacy in the couple. If the couple doesn't work very well together, if they are fighting all the time, you will have to have couple counseling and talk about their life overall. You might use cognitive behavioral approaches or mindfulness. You want to change the way they think about sex. If you want to make them able to be more in the present, you can use mindfulness. This is the new black in sexuological treatment. And then if you think there are a lot of psychological problems in the woman, she might go in a more regular psychodynamic therapy due to psychological problems. That's a specialist treatment. And then we have a lot of other, depending on what type of problem it is. You might recommend lubricants, oil, gels, different kind of lubricants for women with arousal problems. For women with pain and vaginismus, you can suggest dilators to expose them to penetration. Some women with pain will go through surgery as the last choice treatment because they have changes in the vulva that you think will be helped by surgery. Women with pain and vaginismus very often have benefits from physiotherapy, where they learn how to relax the pelvic floor and not have a very hypertonic sexual pelvic floor. And very often you combine these different treatments. So you might add estrogens, you might do sex therapy, and also ask the women to use lubricants. So that's like the toolbox we have, and it depends a little bit on what's the problem and how does it present it and what do we think is the etiology behind the problem. And sometimes we don't know what's the problem really is, and then you would start with sex therapy and try to go from basic and make them rediscover their sexual life. So just to focus on two aspects of women's sexual dysfunction here in the end, I would like to focus on desire, because women very often have desire problems. And I really like this model when we think about the woman entering your office with a desire problem. And this is from an Italian gynecologist called Alessandro Graciutin. There might be a woman that comes to your office and says, I have desire. So that's what we would call, she has a normal drive. And she also has motivation. And then you need to find out, why is she distressed? Why does she come to your office? And that might be a woman with a husband that has more desire than her. And then you need to talk to the couple about that she actually has normal desire. She has a good motivation for having sex, but she might have a different level of her partner. She's not distressed, so that's not a desire problem in her. It's a context. It's a difference in different desires. That could be an example of a woman. Normal motivation, normal desire, but still she thinks there's a problem. Sometimes I see patients, they will come and say, I have desire, I have sex once a week with my partner, but my girlfriend says that they have sex 3 times, so I must be wrong because I only have it once a week. No, you're not wrong. You have desire, you have motivation. You just have sex less times than your neighbor. That's not a dysfunction. Then there might be a woman that says she has a normal drive. No, she has a low drive, but she has a good motivation. And that could be that she really would like to have sex. She likes the partner, but she doesn't feel the drive. And this is where we should think about something biological. So this is where we would start with looking at the hormones, androgens, prolactin, and that what Graciutin calls a libidinal dysfunction, meaning the libido is impaired, meaning it's a drive. So that's the more biological one. Then you might have a woman that actually have a sexual drive, but she doesn't have motivation to have sex. This is where you need to think about the intimacy and relationship, because the woman might say, I masturbate, I have desire for sex, but I don't like to have sex with my partner. This is where you need to look into the relationship, because she actually expresses desire, but she doesn't want to have sex with the partner. So something is happening with them. That could be called sexual dissatisfaction, because something is not satisfying her when she has sex with the partner. And then we have the one that would say, I have low sexual drive, I have low motivation. And this is where we really should think about depression and both biological and relationship factors. So these might be the very difficult cases where there are many aspects that are really impairing the desire and the motivation in this woman. So this is just a try to put the different presentations of sexual desire problems into boxes, saying that sometimes if we take a good history, we can actually find out what is the problem. And the low motivation could also be like a woman with pain, that she would say, I actually have desire for sex, but I'm not very motivated for it because it hurts every time I have sex. And then you understand why she has a low motivation. So that's just some inputs to dealing with low desire in women. If we deal with pain in women, it's so important when we assess the pain that we find out where is it? Is it generalized or is it localized? Is it something that is there when you provoke it, that you put pressure on it? Is it unprovoked? Has it always been there? Is it something that has occurred after not having pain? Is it always there? And how can you describe the pain? Is it mild, moderate, severe, or is it fluctuating? So this is just to try to, pain is not only pain. So it's really important. I usually say that we learn from the details. So if a woman don't have pain all the time, it's so important to find out what is happening when she doesn't have the pain, because that is what we want to happen more instead of what is happening when she has the pain. And women can be difficult to treat. And usually we say that you need to have a multidisciplinary team. And most places in the world, even in my world, we don't have a multidisciplinary team. But it's only to say that when we look at women with pain, we have one track that is physical and gynecological assessment, where we see if there's an infection. Maybe we need an ultrasound of the abdomen and the pelvis. We need maybe a laparoscopy. We might have biopsies, cultures to find out, is there some physical changes that causes the pain? And we also need to have a sexological and psychosocial assessment. How is her sex life? What is happening? Is she stimulated enough? Does she have a psychological, psychiatric disorder like depression or anxiety? Are there sexual trauma? Has she been sexually assaulted? Are there relationship problems? So we need to think in both tracks, and then you collect everything. And depending on what you think is the most important problem, you go into the more medical treatments with pain medication, treating viral, bacterial infections, fungal infections, hormonal treatment. You can, if you have a physiotherapist, you can help her with exercises for the pelvic floor. You can counsel about sexual practice, what to do, what not to do. A lot of women will continue having sex even though they have pain, and that's going to maintain the pain. So you can have counseling about doing something different so she won't have pain. You can have relaxation, mindfulness, and then you can have psychotherapy or sex therapy with the partner, or cognitive behavior therapy to try to deal with pain like you deal with pain other places in the body. And sometimes you need to have several approaches and discuss it with different disciplines. So the trap is that we only focus on the sexual counseling and the woman have an infection. That's not good. The trap is that we focus only on the biological things and forget that actually she doesn't get aroused because she doesn't receive enough stimulation. So we need to include both the biological and the sexological, psychosocial aspects of pain. So this brings me to the story, and it's an Asian story. You all know it, about the blind men describing the elephant. That the story about describing the blind men touch different parts of the elephant, and depending on where they touch the elephant, they would describe an elephant in different ways. And only by combining the impression all the blind men had, you had the whole picture of the elephant. And I think it's the same with women and their sexual problems and sexual function, that we really need to focus biopsychosocially, because if we only describe one part of the elephant, we're going to miss something and we're not going to have the full picture. So this is just to show the sexological elephant. And finally, I will just advertise a little bit for our webinar tomorrow, which is about communication about sexual problems in the clinical setting. If you want, I know it's late because the webinar is tomorrow, but you can go to the issm.info and search on webinars. And here you can also see the future webinars. I showed you the other one that will be in September. They're open for all people. You don't have to be a member. And we have a very, very distinguished faculty and the moderator, we have a distinguished member of SASM. One of them will moderate the session. So if you have the time, you're very welcome to be there. And also, you're very welcome to our annual meeting. It should have been in Japan last year. Due to the pandemic, we had to move it, and now it's going to be a virtual meeting. But I really hope you'll be there, because the fact it's a virtual meeting actually makes it more possible to participate. So if it has caught your interest, go to our webpage and join the meeting. The program is really nice. The program is on our webpage. There are going to be many very exciting presentations on both male and female sexual health. So these were the words, and thank you so much for your attention.
Thank you very much for your wonderful, in-depth discussion, ma'am. Actually, we really enjoyed wholeheartedly. You have spoken so well that very difficult and very complex issue in such a way that it becomes so understandable and very transparent. Thank you. It's really thought-provoking. It's really thought-provoking. And thank you very much for your brilliant and mind-blowing talk. Well, now we'll move to get some questions. But before that, I would like to thank you for inviting us for the webinar and the world meeting. Hopefully,
I hope you'll be there.
We'll be able to attend that.
We also have, I just want to say that we have some grants. If people do not have money to pay, it's possible to apply for grants also to go to the virtual meeting. So please be aware of the possibilities if it's an economical problem. So I hope you'll be there.
Okay, thank you so much. That is for Mohammad Shamsul Hassan. He will take care of this matter. Okay, ma'am, we are going to take a few questions from the chat box, and then probably we'll go to the panel discussion. Many of our members, they wish you very good luck, and they really enjoyed your talk.
Thank you so much.
One of the questions I found here, most welcome, ma'am. Dr. Julasuddin Ahmed, he questioned how negative sexual attitude can be changed in the Hudi and this conservative society. He asked this question to you, ma'am.
So how we can change the negative attitudes in society? Wow, that's a big question. I think it's not easy, but I think that what you are doing in your region is an example of changing negative attitudes. I think that it has to start somewhere, and I think it starts very well from health professionals. And I think that it starts with schools. If you can have more education in schools, and it starts with politicians. So I think it's a little bit like, when you throw the stone in the water and the rings will start to spread. And sometimes we feel that it goes a little bit back. We see that in Europe, that we have some very conservative countries like Poland and Hungary, where they suddenly become more restrictive. So it goes up and down. But I think that information and to use some of the channels where you usually work for human rights, I think that's a way to try to change it. And also try to change it in a way that you show it's not dangerous, because some people think that if we start talking about sex, everyone will behave in a promiscuous way. But if you show that this is something that's important for family life, you will have less divorces, you will have better family life, it's going to be better for families and children. I think you might reach people that religious leaders, political leaders, but it's very difficult. But I think what you're doing now, having a webinar, teaching your children, teaching your colleagues about it, I think that's the way to do it. But it takes a long time.
Thank you. Yes, thank you very much. It's a really humongous task to change the attitude.
Difficult.
Anyway, like you pointed out, madam. Thank you, ma'am. And another question, one of my friends, she asked that she had a patient with premature ovarian insufficient at the age of 40. So she is having hypoactive sexual desire disorder. So how could she treat her patient? One of the questions came from my friend.
So the woman had a premature...
Unmute, ma'am. Unmute yourself and then answer.
Okay. Can you hear me now?
Premature ovarian insufficiency.
Yeah, I think
Yeah.
I'm not a gynecologist, so I apologize, and there might be someone in the audience that know more, but I think that sometimes you would give them hormonal replacement therapy, and sometimes you will give them both estrogens and testosterone, because then you somehow rearrange or install the hormonal milieu. So that's, but I think it's a specialist, either an endocrinologist or gynecologist. So there might be someone on the line that know more about that, but I think that's what we would do in Denmark. And then also talk to her about what is desire, because maybe what the woman is experiencing is the lack of drive that comes from the hormones, but maybe she can find the more motivation, desire, with a lot of focus on intimacy and starting having pleasurable sex, and then desire will grow. So a little bit like women that are in the postmenopausal period, that desire has changed. So it's not something that comes very suddenly, but it's something that might come if you work on it in a different way, because sometimes these women will experience that it's different from what it used to be. You're muted.
Sorry. Okay, thank you, ma'am. Actually, you rightly said, though even you are not gynecologist, they should have menopause hormone therapy if there is no contraindication. Okay, last question, ma'am. Some of the attendee, they asked you, I don't know actually what she wanted to mention is that why female with histrionic personality has greater sexual dysfunction.
They have better sexual dysfunction? Yeah.
No.
It's better or worse?
Yeah. Greater, yes, more.
It's a part of their personality, because sometimes they have problems in like feeling themselves, or so they don't have a dysfunction, but they might have a problematic sexual life, because they try to get emotionally closeness to people by having sex. I think that's one of the easy explanations, but you cannot say a general one. But having personality disorders, sometimes you try to connect with people by sex, because that's the way you can really feel yourself. That's the way you can feel the other person. That's the way you can feel someone likes you. And the easiest way for people to feel someone like them is to have sex. But sometimes it's a very short-term strategy, because you might be abandoned or you might not get the feeling you want. So I think that's what we see with women with personality disorders. They have different difficulties in regulating their emotions, and then they try to show their emotions by having sex. That would be the short response.
Hope our attendee has got the answer. Thank you so much. Let us move to our next part, the panel discussion. And we have a very well-known, reputed experts panelist with us today. This is very happy and very delighted to get them. So let me first introduce Professor. I have got Professor Dr. M.U. Kabir Chaudhary. I can see you. Hi, Assalamu alaikum, sir. Thank you. Professor Dr. M.U. Kabir Chaudhary is a very well-regarded, internationally reputed leading dermatologist in Bangladesh. He is the pioneer skin surgeon in Bangladesh, and he was a professor, former professor of Shamorita Holy Family Medical College Hospital, and he is the president, Association of Cosmetic Dermatological of Bangladesh. He is the chief patron of ADSB, and he was the founder principal of Shamorita Hospital. And we are very, very happy that he is the Shadhinata Padak Reward of Bangladesh. That is the prestigious for his brilliant work. Sir, you are most welcome to this webinar. So my question actually very simple. You here today, you'll just tell us what are the main skin condition that really, really affects the women's health, and you have to say a few words about the whole webinar today. Welcome, Professor Emil Kabir Chaudhary. Sir, unmute, please.
Yeah, I'm unmute করছি. So first of all, I thank ISSM or the organizer to organize such a part of medical science which is totally ignored and which is so missing dimension mainly in our society. And FSD, mainly female sexual dysfunction, is totally ignored. And sometimes women pass their life until menopause, they don't come to a doctor, but they don't know what is orgasm, they don't know what is the sexual satisfaction, and nothing. And these sorts of seminars are very, very encouraging because one thing is very missing in our country, and that is no education, sex education. So your question discuss about the skin condition where the sexual desire is big problem. First of all, I have seen when a patient is in psoriasis and very much distressing condition, it is a morbid condition. Morbidity means a lot of suffering, and those women, they lost their sexual desire. And it is maybe due to psychological level, even some comorbidities like diabetes or other skin condition like pemphigus, pemphigoid, the whole body is involved. And those women are very much distressed in having FSD. We face problem with those patients. But to deal with this problem, we need a teamwork. When a female dysfunction, mainly the gynecologist, are the first doctor to overcome with this situation. And next, we need the sex and sexually transmitted diseases specialist, urologist, and psychologist and a psychiatrist. Very, very important part of treatment of this condition. So here, main question: how we can help those people. If any of this specialty we have discussed had got a disease like pemphigus, pemphigoid, or STD, like a patient is HIV, or a patient is having some genital problem like the LSA, lichen sclerosis atrophica, is a big problem because the vaginal introitus became very much impenetrable. They cannot penetrate because this LSA causes the shortening or the cicatrization or the opening of the introitus became very much difficult to penetrate. And these are the problem in the skin. We usually face the problem in mainly FSD. And also like a patient is herpes simplex or herpes zoster, and this herpes zoster is very painful. And another problem come with us, very, very difficult, is genitodynia or vulvodynia, this sort of vaginodynia or urethrodynia. These sorts of problem also come to us and difficult to explain. And this again, we need help of the friends, urologist and gynecologist. And sometimes the patient is so much distressed about her disease, like the patient says, yeah, psoriasis is not a curable disease, or we have some ulceration or some skin problem like pemphigus, a lot of blisters, and then we need some help from our. Sometimes a patient come and some hormonal disorder, we have to call to our the endocrinologist, and this is teamwork. So these are the skin condition are getting a lot of problem and sexual problem. So this is my appeal to all our specialists. When there is a skin disease like this, please send it to a skin specialist, treat the condition, and tell them when you'll be cured from your psoriasis, or control your psoriasis, or control your pemphigus, or control your LSA, lichen sclerosis atrophica, or other skin diseases. Your desire will come, and FSD will be no more. You'll be sexually very, very vibrant. You can go for sex. And this is also, we need a counseling or by a psychologist sitting to tell them when skin disease goes, and when men they dislike to come a woman having severe erythrodermic psoriasis. Even I have seen the man is going to marry when the patient is having PSS, progressive systemic sclerosis. And there are a lot of skin condition causes main problem with the female sexual dysfunction. And men don't come to a woman is having some vaginal discharge or like ulceration of vagina or having anything, any skin disease. So we should very much communicating to each other to control the skin condition, and then desire will come back. Just to tell the woman, this is the end of your life. You control your skin disease, your desire will come back. But sometimes women think, oh, my life has gone. Also men think life has gone. But no, life is not gone. Life is not end. Life is not very short. life is not short, and so we should think and treat the skin condition. So FSD is not incurable disease. FSD is curable disease. Any source of skin condition there can be treated, can be cured, or can be controlled, and she can have a normal sexual function. Thank you very much for a wonderful question to me. Okay, thank you, Ana Maria, for your wonderful presentation. You have shown all pros and cons of this subject, which is very much ignored in our country and missing dimension. So thank you all the way, because now you are somewhere. I'm in Canada now. I'm in Toronto, but we can participate this sort of webinar. So thank you, and also thank you for invitation to the webinar. We hope to attend those webinars if invited, if it's possible, and we get some knowledge. Every day we learn something. I learned so many things from you today, and this will be a treasure for future life to treat the FSD and have communication with our colleagues of the same subject. Thank you very much. Thank the organizer again to invite me here, and thanks also the repeater to invite me to discuss this few words for me. Thank you very much again.
You're welcome, and thank you for a very important contribution, because I think skin diseases is something that is so overlooked in sexuality. Just the fact that you feel unattractive if you have a skin disease has such a huge impact on both men and women. So thank you so much. It's really a pleasure to meet all of you.
Thank you.
I'm a little embarrassed because I have to leave for another meeting in a few minutes. So it's just to say that if I pop out, that's the reason. I only have about 5 more minutes. So, but thank you so much for the important contribution. I really enjoyed it. Thank you so much. So,
Dr. Ana Maria, just one question. You have
thank you, ma'am. Thank you, Professor Ana Maria, for your kind presence and beautiful talk. Okay, hopefully see you again. Thank you.
I hope to see you all. Yeah. Thank you so much, all of you.
Thank you so much for that well-class lecture. Thank you so much. We really enjoyed it.
I really miss seeing you in person, but I hope we'll see you in the future in person. Thank you.
And a wonderful talk. Hopefully we'll again and see you. So let us, okay, bye-bye. Bye-bye from Sasam School of Bangladesh. Okay, so we were in our exciting panel discussion. Now let me move to our Professor Ferdowsi Begum. Actually, she is our dynamic leader of OGSB, Obstetrics and Bangladesh Gynecological Society of Bangladesh. She's working very hard to improve the women's health in Bangladesh. So let us go to her. May I call upon Professor Ferdowsi Begum to have some words for this webinar and how she's working for the women's health. Professor Ferdowsi Begum, ma'am, please. Unmute, madam.
Assalamu alaikum, and a very good evening to all the panelists, dignitaries. Basically, the presentation was, I think the speaker has left, but it was so vivid and scientific that it was really very beneficial for all of us. It is an eye-opener as well, because many times we neglect, basically do not give due importance to what patient is saying to us. That may be because of we are not giving enough time to the patient, or we are not knowledgeable enough, or patient may not be expressing what she or he, the family wants from us, the couple wants from us. So I think that's a complex issue again. There are multiple factors. It's not only the scientific part of it, the catching the exact dimension of the problem. Because this is not only a clinical problem, sometimes it's so familial and social, it goes up to the psychological level. It's like one fits into another. It may be happening due to a psychological problem or a psychological or mental issue, and then it itself is bringing back the issues again. So it becomes complex. So we must be giving enough time to the patient, listening carefully, and analyzing this into a very scientific way. And I think today's presentation was So I think a stepwise, analytic, and a mastery sort of lecture, I should say. So we must convey this message, and will be benefited from such kind of presentations again and again. And I really appreciate the present learned audience with us. And I must congratulate appreciate the attendance participants of this webinar today. I must, and the organizers and the persons supporting us. So I think, Jinath, I'll personally request you that we'll be benefited from our society. I think once we should invite her for such good presentation for a bigger audience from the obstetricians and gynecological perspective, because that will be really helpful. I understand. Thank you so much.
Heartiest thanks, madam. Thank you so much for your kind presence and beautiful talk. And you're really pointed out that we'll be benefited if the president comes to our meeting. So I would like to request Dr. Shamsul Hassan, you just keep it in your note so that my president of OGSB, she can invite her. Okay. Thank you, madam.
Yeah.
Thank you so much. Thank you, madam. Thank you for your beautiful talk. Now let me move to Professor Muhammad Jahangir Kabir. Professor Muhammad Jahangir Kabir is our another panelist. So we're very much honored to have him. He's a very reputed urologist in Bangladesh. He's the chief consultant, urology and uro-oncology lab at hospital, and he is the academic director of Urology and Transplantation Foundation of Bangladesh. And he's also an adjunct professor of State University of Bangladesh. He's a great researcher. May I welcome Muhammad Jahangir Kabir. So we are very grateful you to come here to attend with us. The first question to you, that many of women, they complain they can't control their urination during the sex. And that is their very sorrows and silent agony. How can you address that? And of course, you have to say few words about today's webinar. Professor Jahangir Kabir. Unmute yourself, please.
Thank you very much. Particularly, thank you for introducing me. I must thank Sasam for arranging this type of webinar. And that was a very eye-opening lecture by Professor Annavadia. I think she covered all the things. I mean, this is a very much we are here from different specialties, and so each and every specialty I would say need to learn from this lecture because she covered all aspects. So I must say thanks again for very nice deliberation. We must remember her talk for a long time, and particularly what I just want to say something about female sexual dysfunction. Sometimes we get the patients with both way around, because we see the patients with a lot of times they suffer from UTI, lower interest symptoms, a lot of vague complaint. They come to us. Actually, on inquiry, we don't find any problem there. We don't find any, but she has taken a lot of antibiotics, a lot of other medications, but she is not at all well. In those patients, if we actually inquire them, we find them that there's some problem with their sexual life. And let's say, for example, a lot of people comes from, a lot of people are working in expatriate workers. They live for 1 to 2 years and they are deprived of sexual activities. And these patients, they actually comes all the time with big symptoms. So we need to address them. We need to address them with antidepressants, not with the antibiotics. And we also find that a lot of patients that we say that suffers from urological problems, they become hypoactive sexual desire problems. Because as you mentioned about incontinence, so we have to address about what is the cause of incontinence. Sometimes they are from the overactive bladder. Sometimes they are from the incontinence because of sphincter deficiency, or sometimes they are in the both. So proper actually identifying their problem, particularly with history taking, sometimes with aerodynamic evaluations, and sometimes clinical examinations can sometimes find out the cause really, and then we need to give them the treatments. Actually a little trick, let them understand that if they go for to visit the toilet and empty her bladder before they go for sexual activity, then sometimes their incontinence is under controls. Anticholinergic, bladder selective anticholinergics sometimes help them. And if they don't, if they suffer from stress incontinence, severe degree of stress incontinence, then it sometimes needs some sling surgery or operations for that. So these are the things we must address, particularly if suffers from incontinence. And I think other thing, most of the things has been covered already. So I'm already too late in the night, so I don't want to.
Thank you. Thank you very much for your kind words for the webinar and your wonderful suggestion regarding the incontinence and female sexual dysfunction. So we have finished our very beautiful and very informative panel discussion. Now we have got two special guests, very renowned. So I would like to invite, first of all, Dr. Lasantha Malaviz. Just I want to say a few words about him. He's a great academician and past president of SASUM, that is South Asian Society of Sexual Medicine. We had a great time in Sri Lanka with him. And he holds the PhD in sexual medicine and in diploma in psychosexual medicine from the Institute of Psychosexual Medicine, London. And he is the former secretary and vice president of Sri Lanka Medical Association. He is currently the chair of medical committee of Family Planning Association of Sri Lanka. So I would like to welcome Dr. Lasantha Malaviz. And please, we like to know or we like to listen a few words from you about the whole webinar today. And we're very happy to get you here today.
Thank you so much, Sinet. I think it's a beautiful, wonderful opportunity for me to be here today. And I think, first of all, I must congratulate Dr. Samshul. He always do things in style. So I think he has done another beautiful event. And I think Anna Maria's lecture was very comprehensive, very clear, simple. And that's the beauty of class, the world authority, when someone who's an authority in that speaks. So I think well done. And I'm so happy that the Bangladesh the academy, this sexual medicine school is progressing so well. I think it's setting examples for the whole world. So I congratulate all of you for beautiful work done in Bangladesh. All the best, and looking forward to see you soon, somewhere soon.
Thank you. Thank you very much for a wonderful talk. Hopefully we'll meet together somewhere, really.
Yes.
Okay, thank you so much. Now I'd like to move to Dr. Vasan Satyasreni. Well, Dr. Vasan is the most knowledgeable, dynamic president of SASUM. And he is actually, he is the institution. He doesn't need any introduction for him. He's the stalwart of the sexual medicine. And of course, he's a trained and certified urologist. And he pioneered the concept of comprehensive andrological diagnosis and treatment approach, especially in the male infertility in India and across the world. So I'd like to welcome Dr. Vasan, please, for your remarks about the webinar today. Dr. Vasan, please.
Thank you very much, ma'am. And thank you. I think thanks to all of you. I think it was brilliantly conducted. And this was one of the most scientific webinars I've seen. I think all of us realize that female sexual dysfunction is something, a big challenge in this part of the world. Basically because for us, for women to express themselves itself is a big thing. And many of them suffer in silence. And I think there is also a dearth of knowledge among clinicians. And this was a wonderful opportunity for all of us, including myself, to learn the basics of how to diagnose, how to manage. And I think Anna Maria summed it up, and she's no less of an authority in this field than and one of the foremost authority in this field. And I think SASM School Bangladesh and the team Bangladesh, including SAS Shamshul, everybody put in a lot of effort. And I've seen a series of webinars which are all well conducted, scientifically managed, and brilliantly hosted. Thank you all, and I wish you all the best, and I hope to see many more webinars, and we will continue to participate. Thank you.
Thank you. Thank you very much for a very wonderful, inspiring talk. Well, now we are just at the end of our webinar, and now the most dynamic, and today I would like to call upon Mohammad Shamsul Hassan. Actually, he did a lot of works to have this successful webinar. He was working silently behind. And Dr. Mohammad Shamsul Hassan, a brilliant fellow of European Committee of Sexual Medicine, and he is certified psychosexuology, and he is the next president-elect of SASO. And he is the chair of the Young Trainee Committee, ISSM, an International Society of Sexual Medicine. And of course, he's working as an associate professor in the Department of the Psychiatry of Bangabandhu Sheikh Mujib University, a prestigious university in Bangladesh, Dhaka. Most welcome, Mohammad Shamsul Hassan, for your vote of thanks.
Thank you, madam. Thank you. Thank you. You have dynamically contributed the session. Probably our president, past president of OGSB, Professor Roshan madam, is having a serious meeting with doctors, so probably she left. I just want to give my heartfelt thanks. My heartfelt thanks to Professor Anna Maria, because in her busy schedule, she has provided us a wonderful, presentation on female sexuality. All of us have learned, and you know that you was our faculty in Oxford, and she did brilliant. Every time I see her presentation, and I feel amazed that many things to learn. I just want to give my thanks to Professor Ferdowsi Begum madam. In her busy schedule, she have came here, president of OGSB, and we would like to have more and more, coordination with the different societies in Bangladesh, so that we can have, a multidisciplinary approach. I just want to thank Professor Jahangir Kabir, sir, urology. He's a chief urologist. I just want to give thanks to Professor M. Kabir Choudhury. He is he's a philanthropic, teacher, and he has got many dimensions you have expressed. But in his busy schedule, he has came here. Thank you, sir, for joining us from a very far away. And I, of course, want to thank Dr. Lasat. He's a good friend of us, and he has every time we arrange SASM School Bangladesh, he is there. We know that he has got a lot of academic qualifications, but still he is the top florist in Sri Lanka. Sri Lanka knows him for his, beautiful, decoration and floral. He has running the with lot many flowers. If you go there and ask Lasat Flora, everyone knows him, apart from his scientific background. I just want to thank Dr. Basan sir, because he is always with us, and like Professor Jinat Madam said, that he is a knowledge. He is a sheep of knowledge. He has got everything about. I think, and last but not least, Jinat Madam for being the very dynamic moderator. My small contribution to few people who have worked basically behind the scene. Shamsul of UNIMED, he has did all the hard work, and Dr. Mahmoud from dermatology. He's a full of energy. And also, I just want to give thanks to all the audience who has been there. And I just want to give two information. One is we have a small study in Bangabandhu Medical University on female sexual dysfunction. We have used FSFI, and we have seen 50% of the attendees who have attended the the outpatient department had got female sexual dysfunction. They didn't come for female sexual dysfunction, but while we saw there in the gynecology, endocrine, and psychiatry, we saw they have got a dysfunction. So it's a very underrated and under-informed subject, and we need to have more future collaborative studies with the help of gynecology and endocrine and other societies. And also in the next webinar, there will be Dr. Egekan Serifoglu. He will be talking on premature ejaculation. I think it will be a wonderful presentation too. It will be on 15th of September. So thank you all. Thanks all the dignitaries for being with Sasam School Bangladesh. We are trying hard to, enrich the sexual knowledge to bring to the all the specialists. Thank you all. Thank you from Sasam School.
Thank you very much for your wonderful vote of thanks. Well, we are at the end of the session. And of course, Sasam School of Bangladesh is very much grateful. And we are extending our heartfelt gratitude to each and everyone who participated in this webinar. And of course, the dignitaries, we are really, really honored to have you all today. With this, hopefully Corona will be, it will go within few years probably, but probably will be a better life. Then we can meet together. We can meet virtually, not in virtually. With this, stay everybody happy and safe. Bye-bye from the School of Sasam, Bangladesh.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.